Right. Well, thanks for coming on a Saturday afternoon. You guys sound like very keen students to do this on a weekend. I don't know. I'm not sure if I did this when I was younger. Um, so, as Alana had mentioned, I'm a radiation oncologist. I'm a cancer doctor that uses radiation for treatment. I work at the Tom Baker Cancer Center in Calgary, and I'm a clinical assistant professor at the University of Calgary. And my main area of focus is breast cancer, and I'm the Alberta Health Services Provincial Breast Tumor Team Lead. So I think most of the people in the audience are junior high or high school students that are local within Calgary. Okay, good. So it'll be kind of nice to kind of go through. I'll take it to an appropriate level and provide some local context as well. These are my disclosures, just some honorariums from some drug companies. So the hope is that today I can kind of talk a little bit about what is modeling and my interpretation of mathematical modeling and its application in medicine, particularly in cancer care, just because I'm an oncologist. And then we thought it'd be interesting to kind of understand modeling and its use in the current day context with the global pandemic of COVID-19 and using some local data from Alberta Health and Alberta Health Services as well. So, as everybody in the world, doctors also use Google. And so when we were trying to understand something, one of the first things in this modern era is to kind of just Google what is mathematical modeling. And the first 3 hits I got are from Wikipedia, this paper from, I think, 2008 in the United Kingdom, and one from Simon Fraser University. So let's click on all those 3 links and see what they say. So I'm just going to move this panel. What is modeling? According to Wikipedia, it's a description of a physical system using mathematical concepts and language. And the process of developing that mathematical model is termed mathematical modeling. A model may help to explain a system and to study the effects of the different components and to predict about behavior. This is a paper that you can click on the link below, or just when you have access to, perhaps maybe at the end of this webinar, Alana can send out the links somehow to all the attendees, or just write this down or copy it from the webinar that's recorded. So basically you build this model, you study it, you test it, and then you use it. So it's a iterative process, something called what we use in what we call in quality improvement, the PDSA cycle, the plan, do, study, act cycle. And why do mathematical model? Like as Alana alluded to, it's hoping to take observations from the real world, put it into a conceptual model, play with some assumptions, do some sensitivity analysis, predict some outcomes, and then apply it to the real world so for that we can plan things. And then it would, again, be an iterative process that we can modify the inputs to reevaluate the outputs. So in that paper, in this paper from Simon Fraser University, which is a really good paper, actually, I was reading last night, basically, why are we doing this modeling? What are we looking for? What do we want to know? What do we know? We put those things that we do know into a model and certain mathematical formulas that provide us with extrapolation or interpolation of the data to predict for certain outcomes that we're looking for, and then seeing whether those predictions are valid or not. So in my world, like we use Google for just everyday stuff, but in the world of medicine, we use something called PubMed. And so it's a search engine that looks at medical literature. So if you're interested in medicine and you want to learn more, or let's say even everyday life, you want to learn more about some kind of medical illness that your family or friend may have to help them. One of the places that we always look for up-to-date literature is PubMed. And so when I put in mathematical modeling into the PubMed search engine, you can see what's interesting is that they tell you how many papers that there are that talk about mathematical modeling in the science world since 1933. And you can see that there's really nothing up until more recently, where there's been a trend, and I hovered my little mouse or arrow above 2013, where there was a peak of 110,000 publications looking at mathematically modeling. And most of these are scientific papers, peer-reviewed usually, other than some letters of the editors or some reviews. And you can see like the second paper that is the hit is The Many Faces of Mathematical Modeling in Oncology. So I encourage you, if you're interested, not necessarily in oncology, but in mathematical modeling, just kind of look up papers, read about their methodology, and see their potential clinical application. So in this paper that I looked at from PubMed, most of them you can just download as a PDF, or some require a paywall. If you're heading to university, you usually have access to a lot of these papers. But the authors of this review paper talk about a mathematical model being a distillation of biologically complex matters into a manageable representation that is complex enough to keep the general principles of the system intact, but simple enough to kind of play with the potential variables to make predictions about potential outcomes, because none of these models are truly definitive. They can help us understand complex systems and then help us generate or generate hypotheses, or create hypothesis generating tests that we can kind of think about for clinical trials. So this is a figure in that paper that talks about how we can use models to kind of come up with biological hypotheses, and then plug those into certain models and put in different assumptions and define parameters to formulate a model that will come out with some certain predictions that we need to validate before we can, and then refine before we can actually use it in a reliable manner. And I'll show you a real world context in terms of my research at work, and also with respect to COVID-19. So there's thought to be two different approaches to biological modeling. One is from a top-down approach, and the other is from a bottom-up. And so from the top-down approach, it's kind of like using large data sets. So you might have heard, and you might hear from other people in this webinar today about leveraging big data, large clinical data sets in the world of medicine, using AI, machine learning to kind of harvest the pertinent information and common themes within this big data to develop a model such that we could predict certain scenarios and outcomes. They talk about the strengths of doing that, again, particularly with machine learning and artificial intelligence, but it only detects correlation, not necessarily causation. So ultimately, if you do have a model that suggests one benefit to one treatment or one road that you should be taking, ultimately you would want to run that through a clinical trial, either with drug development with phase 1, phase 2, or if there's a clinical already available, testing that in a phase 3 randomized trial. And then the other way to do it is through a mechanistic model, where it's a bit more using like smaller like real data, and then developing a bigger model to kind of help try to explain a certain hypothesis. But it can be somewhat biased because you're using more smaller bits of data that lend itself to bias. So here's in that paper, they talk about how there's this pipeline of that you could be using to develop tumor models to determine the best therapy for a certain patient. So they always talk about the right patient, the right time, the right treatment, and so really it's just gathering data analyzing that data, plugging it into a certain model that fits, doing some simulations, like multiple treatment simulations or Monte Carlo simulations, and then developing some kind of decision tree, applying that treatment, and then ultimately in real life, hopefully applying that to a real patient population. I must admit, though, that there are much limitations in models. They really just are hypothesis generating and try to inform direction for real clinical trials, and that's ultimately where the evidence-based medicine that guides my treatment decision making for patients ultimately comes from randomized clinical trials. So that's just a little brief introduction to mathematical modeling. It's just to give you a taste. And I must admit, it's something that I don't think about on a daily basis. It is something there are two types of people that are interested in modeling. One, and you just have to think about which bucket you kind of fit under. The ones that are more interested in the mathematical side, or the methodology people, and the others are those that are interested in modeling to answer a certain question. And so that I think I'm more of the latter, where I require the assistance of, very smart guys in epidemiology and statistics, like biostats that are at your university, that kind of understand the methodology piece, and I provide the clinical context and the question and the potential inputs. So this is an example of a study that I did when I was a resident in training to be an oncologist, and I did my training all at Western in London, Ontario. And basically what we wanted to look at was a discrete event simulation model to see how we could what the impact of different variables would be to affect radiation treatment planning. So you guys might not know what a radiation oncologist does, but basically there's three types of oncologists, and we're all cancer doctors. There's surgical oncologists, they cut out the breast cancer. The medical oncologists, they give the chemotherapy. And I'm the radiation oncologist, where I give radiation to the remaining breast or to the lymph nodes, such to reduce the risk of local regional recurrence. And so when we plan radiation treatment, there's a process to get patients through treatment. So and we'll walk through this just to kind of run through what a discrete event simulation model looks like. So the patient arrives, and I'm not sure if you can see my little mouse there, but they arrive, they see me, we have a discussion about the intent, benefits, and side effects of radiotherapy, and then the patient can decide whether they want that radiation treatment or not. And usually they do, but some of them do reject it, and then they're out of the system, they're out of the model. If they do accept treatment, they require a CT scan that where we plan them in a certain position, and we plan their radiation treatment just for them in for their unique scenario or reason for radiation. Afterwards, we do some contouring of the breast and the organs at risk, such as the heart and the lungs, and then we do some quality assurance. And I personally do some contouring. There's some dosimetry for the radiotherapy plan, and then I approve it. Physics does a quality assurance check. Dosimetry does a quality assurance check. It goes to the calc station, and then ultimately the patient takes treatment. So let's say a patient sees me for treatment on a Monday, and they're ready for treatment. They don't necessarily start radiation the next day. It requires a lot of effort, usually 2 weeks of radiotherapy planning before the patient can actually start radiation treatment. So we wanted to kind of see what would happen in scenarios where so it normally takes 14 days to develop this plan. What would happen if we hired one more dosimetrist to plan the radiation, and that cuts the ready to treat the treatment time down from 14 days to 10 days. But what happens if one dosimetrist is sick? And this is particularly relevant in light of COVID-19, where we've had some absences of staff due to illness or workup for COVID-19. What would happen? So we would see that there would be a reduction or a longer time for patients to get started on treatment, especially if there's been one less physicist to do the quality assurance. And then what would happen if we had one more physicist? Again, it cuts things down. So it's really just playing with a whole bunch of variables to understand the output. This is the final conclusion. Basically, it's saying ultimately, and it kind of seems like it's obvious that if you hire more physicists and dosimetrists, then you can cut down the time that the patients get on treatment. And if you have less of them, then you have less capacity to get them patients treated started early. But it just provides you a quantitative way to kind of measure that, so that our administrators in the hospital and in the cancer center can plan for these kind of delays. A brief I'll talk about is what I did when I took a year off and did my MBA, and I met a couple of really smart like biostatisticians as well, and people in epidemiology, and we were really, so they were leveraging my experience with medicine and cancer care, and I was kind of leveraging their abilities to do Markup models. So so the last one we talked about was a discrete event simulation model. This is something called a Markup model, and again, there's lots of models there, and if you're interested, again, if you're more on the mathematical methodology piece, then I would encourage you to do more reading about what types of models are available. Whereas if you're more interested in the downstream, like the final outcome, then you can kind of think about medicine, think about the clinical questions, the unknowns that we don't know, and maybe perhaps connecting with the methodology guys to kind of talk about how you can collaborate to kind of come out to use a model to get those answers that you're looking for. So here we just did a simple decision tree initially, where patients with head and neck cancers would either get a platinum-based chemo, it's a type of chemotherapy, or using some monoclonal antibodies that are attached to the chemotherapy that are more selectively targeting the cancer cells in addition to the chemotherapy. And so we generated a couple models. This is just with chemo. Either you are stable on chemo, or you progress, or you die. But then we want to see what happens when you add this monoclonal antibody called cetuximab, which has been shown to provide a little bit of benefit, but comes with a little bit more toxicity perhaps, and made a bit more of a complex model to understand how you transition from using cetuximab from stable disease to progression, or stable with adverse events or side effects, or death as a final transition state. And so basically, in a nutshell, without getting too complicated, is that we found that when we looked at the addition of this monoclonal antibody to chemotherapy, it increased something called the quality adjusted life year by only 0.093 quality adjusted life years at a cost of about $36,000. So we took from Ontario case costing initiatives. We took cost estimates from where I used to work, London Health Sciences Center, and then we plugged all these into these numbers into the model with the different transition probabilities. And again, it sounds kind of complicated, but that's where you have some methodologists, and perhaps you in the audience today will become one of these methodologists that would have a far better understanding. And what I'm trying to achieve is, what is the incremental cost effectiveness ratio? That is, what is the quality adjusted life year divided by the cost of this drug? And when you take this $36,000 and you divide it by the 0.093, it gives you incremental or cost effectiveness ratio, or an ICER, of $386,000. And normally when governments, and particularly in Canada, or insurance payers in the US, look at whether they should fund a drug for a patient, whether it's worth it, they look at typically ICERs of about $100,000. So based on our analysis, we thought that the the benefit, the cost effectiveness of this drug wasn't worth the cost for the marginal benefit in terms of quality adjusted life years saved. Again, this does not to say shouldn't use the drug in this. Perhaps the government could use this information to kind of have a discussion with the pharmaceutical industries to say what is an appropriate amount that we should be paying for it from a public perspective, and that might help the government with negotiations. And so that's where this kind of clinical usefulness comes in. All right, just looking at my time. I think I have like 15 more minutes. So we thought we'd kind of talk about how you could use modeling in the current context of the global pandemic. So this data is a little bit older, but it's available to the public. And I know some of my colleagues were involved in this modeling, but I personally wasn't, but it's available to the public. If you go to alberta.ca and just Google COVID cases, you can scroll down and you'll find what the modeling, how they did the modeling. They weren't very specific or explicit in terms of the methodology piece, but it does give you a kind of an idea of how modeling can be used to kind of help in everyday life. So first, you gotta kind of know what the current situation is. So this is a bit outdated. They only have the April data up there on the website, but basically they looked at data and compared the number of cases in Alberta compared to other countries. And, the concern, initially with the global pandemic early on was like there seemed to be like major outbreaks in Italy, starting to creep up in the United States, Spain as well. And they kind of just mapped it in terms of confirmed cases per 10,000 people or of the population. And just to see a current status, just to get a sense of what the current baseline is. And so this is just kind of more interesting in terms of understanding case fatality ratios. So, the pediatric population at the time, as of April 6th, so when this was really early on, I think schools shut down March the 13th or something like that. And so this was just a few weeks after schools kind of shut down. That's when people can kind of remember where were you when this happened kind of thing. So at the time, at least in Alberta, we had about 150 cases in the pediatric patient population and 0 deaths, thank God. But you could see that there were more deaths in the elderly patient population in the long-term care facilities, despite the low number of cases. So for about 25% of any positive case would ultimately result in a fatality. And so that's the concern with COVID-19, is really that you want to protect your grandparents and those that are immunocompromised in my world with cancer care. So many other jurisdictions, not only Alberta, but like BC, other provinces, the United States, use data that from places that have it's kind of like, I'm not sure if anyone if you guys have seen Tenet, the new movie out right now, but it's kind of using future information to kind of plan the current state. And so we're kind of using the future state in China and Italy to kind of model the spread in Alberta, or that's what they did back in March and April. And so Alberta modeled 2 scenarios, probable and like worst case scenario, or elevated. Elevated sounds a little bit better than worst case scenario. But probable scenario where for every case there's 1 or 2 people infected, and this was something we call the R naught. And this is, a scenario where Alberta Health deemed it was in line with the UK early on before they kind of got out of control. And then an elevated scenario where the R naught is 2, so that is for every positive case, there's 2 people are infected. That's the infectivity or infectiousness of this disease. Or an extreme scenario where the R naught is 3. And that's where, we wouldn't, if we didn't enact any policies like in Italy initially early on, or the United States without the lockdowns, or lack of social distancing or physical distancing, wouldn't, lack of proper public health measures to to inform the public of hand hygiene, using masks, socially distancing or physically distancing. So they kind of did this in a nice, simple kind of illustrative an illustration just for the public. And basically, the probable scenario was that we would have seen our mid-peak in May with about 800,000 infections and about 400 to 3,000 deaths. And this is, again, you might be thinking, what? That's such a big range, 400 deaths versus 3,000 deaths. And that's just the sensitivity, the confidence intervals that with all these underlying assumptions, right? That the models are not perfect. They are based on assumptions, and whatever assumptions that you put in affects the outcome. And there's a sensitivity analysis that you need to do with some kind of margin of error because you can't totally predict it perfectly. Then they have this elevated scenario where you have a peak earlier on of 1 million infections and about 500 to 7,000 deaths. And then the extreme case scenario, which again, we've been very fortunate in Alberta, is that, we do have, with, Dr. Dina Hinshaw, and a very proactive public health department. But the extreme case scenario would have been like an infection rate of about maybe up to 1.5 million people with a significant number of deaths. So using this, the Alberta Health and Alberta Health Services wanted to kind of use these different scenarios to kind of better plan like what is our current capacity in our hospitals, and whether we should be increasing that capacity. So again, this is an example of how mathematical modeling can help drive policy, administrative policy, hospital policy to help better plan. And so using that probable scenario of 800,000 infections, they assumed that about 10% of those infections would require hospitalization. So that's where you get that 800 number. And so, actually it's probably more like 1%, right? So 800 out of 800,000. So 1%. And of those hospitalizations, a quarter of them, so 200 out of 800, would require an ICU admission. And that's where you need to be admitted for intubation and ventilation. And then under the elevated scenario, where we kind of talked about a 1.5 million infection rate, about 1,500 would require hospitalization. And again, using that same principle, about 25% requiring ICU admission, that we need 400 critical care beds. So then they look at the existing capacity in Alberta. So we have 100 hospitals in Alberta. And this was kind of a good, cool learning experience for me, just because I don't really look at this. I'm just kind of focused in my own world at the Tom Baker at the Foothills Hospital. But in Alberta, we have 8,500 hospital beds, 300 ICU beds, and about 500 ventilators. And so basically, using those models and those projections, we can kind of see how many more hospital beds we would need and how would we achieve that. So basically, what we did was we shut down elective surgeries back in March and April, and we saved those beds on the surgical floors just in case this peak would have come. We transferred patients that were not acutely ill to more long-term care facilities or in the community back home if they could. And again, there's always this thing where it's all about benefits and risks, and you might be thinking, well, why wouldn't they just discharge home earlier? Well, just the balance of risk and benefit changes things, and the need for having that capacity might have expedited some discharges. And then they just use these different probable or elevated risk projections to kind of determine where they are at in terms of their acute care capacity or hospital beds, and then how much more that they would need depending on where we're at in terms of the probable or elevated risk scenario. And they did the same thing for ICUs. So basically, they added ICU beds to ICU rooms. They shut down the ORs, and they changed some of them to be ready for ICU beds. So, because basically, when you're undergoing general anesthesia for a surgery, you're intubated on a ventilator. So it's the same kind of equipment and equipment that you would use whether you're operating or admitting a patient to the ICU. And then with more ICU beds, you need more ventilators. So a ventilator is just a breathing machine. So basically what we do is we stick an endotracheal tube down the patient's throat into the trachea to connect to the lungs, connect it to the ventilator, and that breathes for the patient. And then the thought was like, where do we buy these ventilators? It'd be other resources within the cities, locally, provincially, and nationally. So this is a scenario where they kind of just talk about, again, probable versus elevated scenarios in terms of building capacity for ICUs and ventilators. And this is a kind of a final slide of like all the different scenarios that they would consider in terms of extreme, elevated, and probable hospitalizations, ICU, and deaths. And you can see, you know, on the bottom right-hand corner here, that the worst case scenario that they were kind of thinking about back in April was we would have about 640 deaths, probable about 100, or sorry, elevated about 100, and probable about 50. And so like I talked about earlier, how models are a bit dynamic and based on a lot of assumptions, and there's an iterative process to doing it. So they updated this model at the end of April. So the data that I showed you before was from April 8th. And so they updated it, and this was a crunch time back in April when we were all kind of up we were all on alert about this potential peak, and we didn't really know what was coming. At the end of April, we kind of looked at all of our cases, and at the time, at the end of April, you know, we were pretty good. Like the total number of cases only at about 5,000, as opposed to the 800,000 that we were kind of thinking in the good case scenario, and 80 deaths as of April 28th. The trend back then at the end of April was only 82 hospitalized and about 20 in the ICU, and so. And I presume Alberta Health is doing this on a weekly, if not a monthly, if not weekly basis, just updating their modeling just with the current caseload, and then just carefully watching what the hospitalization rates are and what the ICU capacity is, and certainly the rate of community spread with the COVID-19. So here. And this is out of date, obviously, April 28th, but it's only available on the website. But you can imagine that bar graph at the bottom is what the actual hospitalization rate is compared to our low, probable, and elevated risk scenarios. So I would say Alberta is doing a pretty good job compared to what the worst case scenario with that elevated, and this is not even including the extreme case scenario. So kudos to everyone out there for doing your part to help flatten the curve. And that's what we're talking about, flattening this curve so that not necessarily that we don't all get infected, because one of us will and likely do well to recover from it. It's just that if we do our part to you know, maintain physical distancing, good hand hygiene, and wear our masks, that we could lower this peak that would exceed the capacity of us being able to take care of patients in the hospital and in the ICU. That's pretty much it. That's just an overview of modeling in medicine from my perspective. I'm on Twitter if you guys want to just DM me or follow me in terms of what I do for cancer care in Alberta, and that's pretty much it.
Great. Thank you so much, Dr. Kao, for sharing your knowledge and experiences with us. Obviously, hearing about the behind-the-scenes work of AHS these past few months is definitely something our attendees may have felt curious or even uneasy about before. In about half an hour, we'll check in with you again for the question and answer period. And now we'll get started with our second speaker.